old saying, health is wealth. And I bet 2025 is a year people want to get both good health and some very good wealth. So this morning we're talking about your health. How well did we do in 2024? And it's talking about access to healthcare for average Nigerians and what are the plans for 2025? We're joined by the MD, Anambra State Health Insurance Agency, which also operates at the national level. Dr. Simeon Onyemachi is also a member, Forum of CEOs of state social health insurance agencies in Nigeria. Joins us from our Abuja studio. Welcome to the Morning Brief, Dr. Onyemachi, and let me say Happy New Year to you.
Thank you so much, Kayode, and good morning to you. Happy New Year too.
I don't know what 2024 was like for you, particularly in trying to provide healthcare as a social service, really, to those who might not be able to afford it, really. So maybe we'll start from there, because I know the Minister of Health came up with this policy, spoke highly about it, but really this is where the rubber meets the road. All of the conversations, all of the meetings and all really boils down to how the average Nigerian is able to get access to healthcare. So maybe give us a quick review of the highs and lows of 2024 in terms of healthcare access, rather.
Yeah, thank you so much. And just to say that in the health sector in 2024, we really will say that we had a lot of motion, as well as a lot of results, not just the motion, but then when you are a player in the field, you really can tell clearly when the motion is quite strategic, when it is goal-oriented. So we have, quite frankly, a coordinating minister for healthcare, Professor Mohammed Ali Pate, who is laser-focused in terms of what he wants to achieve, but then to underscore that focus in the Presidential Health Sector Renewal Investment Initiative, he has put in place a lot of structures in place with regards the various players at the national level, i.e. the National Health Insurance Authority, the SWOP office, coordination office, the National Primary Health Recruitment Agency, as well as, most importantly, understanding that there is no federal citizen in this country. We are all members of one of the federating units or the other as subnationals. So the intentional approach towards galvanizing the actors at the subnational levels, whether it be at the level of our state governors, our principals, or down to the local government level with engagements with ALGON, especially in the light of the current topical issue around autonomy. But then to underscore what has happened clearly is to say that so far we have that when you want to improve health outcomes, right, it is very important to have financial access, and that underscores the entire discussion around universal health coverage, because universal health coverage is such a time when everyone, wherever they reside, have access to healthcare that is of sufficient quality to be effective for the particular need that they have. So working hand in glove with...
Pardon me, and I caught the point where you said there was a lot of motion and some sort of improvement as well. So let's cut to the chase. I just wanted to get a background because there's a lot to cover. We know that healthcare is expensive. Just getting equipment, for example, for X-ray, you know how much that costs, right? But people need these services to ensure that they live a better life. So I just want to go straight to the heart of it, really, because it looks 2025 is a year where we just go straight to it, we just cut to the chase. So how much does it cost on an average, for example, to give a package, a healthcare package to an average Nigerian, at least from your end? How much does it cost?
Thank you. We have 36 states of Nigeria with the FCT all having a functional state social health insurance agency. Every state in Nigeria. In the past, we used to have about 2 states that were delayed, but as of 2024, every state government in Nigeria have social health insurance scheme And the reason why this is important, I'll get to your question in a second, is that it is critical for people wherever they reside to be able to purchase a benefit package that will take care of their healthcare needs, whether preventive, promotive, curative, rehabilitative, as the case may be. At the federal level, we have operated the National Health Insurance Scheme. We had done that for about 19 years. This year will make it 20 years since the operationalization of that. But Nigeria, understanding clearly at the review sometime around between 2012 and 2014, seeing that our coverage, the people in Nigeria, our citizens and residents who have access to healthcare when they need it without suffering catastrophic health expenditure, were somewhere around less than 3%, and that was unacceptable. So the conscious policy of decentralization was brought to motion, that look, every state government needs to have a state health insurance scheme to take these services down to the people at the grassroots, using the structures of the various states, understanding that our local dynamics, the contextualization of spreading the message of the importance of having a prepaid method for assessing healthcare, rather than what I prefer to call cash and carry health system, where today you have money, you are able to pay to go to the hospital and what have you. When you do not have, then you just begin to pray to God, or you wait until you die, or looking for somebody to bail you out. But then, with what has happened between 2016 and today, every state health insurance, every state government establishing a functional health insurance scheme with a benefit package that mirrors almost what the National Health Insurance Scheme have, what the National Insurance Authority is administering as National Health Insurance Scheme. So from state to state, these benefit packages vary, but in some, and the range is between 8,500 to about 19,000 naira across our states. The reason why we have these different benefit packages for the state social health insurance schemes is for the fact that you have subsidy being injected by the various state governments. And I say this with all sense of responsibility, that this is really quite underreported, the role that the state governors are playing in ensuring financial access to healthcare. A lot of the benefit packages we have cannot be costed given proper actuarial science at less than 30 to 50,000 naira. But most of our state governments have subsidized these benefit packages so that our people can go to hospitals when they need it, access consultation services, pharmaceutical services, and what have you. So that's as far as it goes with the cost of the benefit package. Yeah.
Dr. Onyemachi, let's connect some of the things that the policymakers like yourself are touting as against what is obtainable. So in terms of this package, what can it do? Because besides what, for instance, my company provides, I also signed up for another HMO, and I remember I wanted to do something and all kinds of conditions. I didn't renew it anymore because it was just a waste of my money. So what can this package do? I know you're saying there's a subsidy. What can it do? What can it do, especially for the primary healthcare level? And what's the level of adherence by health workers themselves? Because we've seen situations where you work in certain places and you have this insurance or social healthcare insurance, and then the way you're treated is not like somebody who is bringing money out of pocket. I want you to marry that, because that is that is where we will now score the government high or terribly low.
Yeah, thank you. Denying what you have just said will be just a play in the fool, because we have a lot of factors that have militated against our progress. But whereas we have those challenges, it's important to also say that today, the coverage of health insurance in Nigeria has moved from where we used to be abysmal, below 5%, to currently at 9% average for the country. But this also is a range across the country. So given that today we have 9% coverage and the confidence that people have in paying health insurance premium and renewing across, it is important to understand the challenges that have militated against us taking it beyond the current coverage that we have. One of it is what you alluded to. When people get to healthcare providers not getting the right quality of care, you get clearly that there are two aspects. We are the demand side. For example, you pay me your health insurance premium as an agency, say Kaduna State Health Insurance Agency, Lagos State Health Insurance Agency, Anambra State Health Insurance Agency. You have signed on to our policy. We have given you all of our benefit packages. You have chosen a healthcare provider. You get to that facility. Certain contracts were entered into to the points of service level agreements to say between the agency and the healthcare providers, we are the purchasers. You have these Nigerians, residents of our various states, who have paid their premium. Using Anambra, for example, you pay your 12,000 naira premium per person per year, and then you get to the healthcare provider's point, which is the supply side. And you get there, then you are told, oh, you have come with health insurance card, sit over there. Let us attend to those who have paid. But then that's where there is a role for every one of us, a role of informing our people. We do sensitizations regularly, saying to the beneficiaries, what has made the developed societies get to where they are today is what you commonly see everywhere. You are in a bus station, you keep hearing, when you see something, you say something. See it, say it, and we'll sort it. But in our own case, you have that
Mr. Onyemaechi.
I'm not trying to pass the buck, but this is a clear issue that we have. People get to facilities, they have these shabby treatments, there are redress mechanisms, 24-hour call centers, they are not calling. You get that providers are not being called out, and I'm using this platform actually to call them out. The contract we have is to say the social health insurance scheme pay these providers capitation, for example, pay them fee for service. We pay all of these monies. There is pricing issues. That is where they may hide to say there's inflation catching up with the amounts you pay. But then we have a mechanism to constantly review.
Isn't that itself suggestive? Isn't that itself suggestive of, you know, the healthcare policies itself missing the mark in the sector, not just the inability to pay capitation or any other fees to the providers? Jeffrey's question is instructive to the extent that does the healthcare insurance scheme itself provide for challenges such as diabetes, for which, you know, Nigeria is reporting the deaths of about 22,000 persons annually? Those sufferers are spending more than they can even afford in terms of out of pocket on, you know, funding their healthcare challenge. You could look at kidney diseases, what Nigerians are spending, those who are suffering from that disease, on, you know, what do they call it now? Dialysis. And we could look at tuberculosis and all those other healthcare challenges. The scheme itself, for those who are even on it, is unable to cover those challenges. So isn't there a mismatch somewhere, or the healthcare scheme itself has not fulfilled its purpose? I'd like you to speak to that.
Yeah, thank you so much. I will say here, and I want it to be put on record, that there is no state social health insurance scheme in Nigeria today, the 36+1 of us, that our benefit packages do not cover these chronic diseases. Hypertension, diabetes, tuberculosis is a given, HIV care, and what have you. But you have special programs of interventions taking care of some of these. However, the chronic conditions, just to underscore that, at least 80% of the reasons why our people die from preventable causes are covered in our benefit packages. You just need to look at these benefit packages from state to state, because they all mirror. I can tell you for certain, I'm the chairman of the Forum of the CEOs of State Social Health Insurance Agencies in Nigeria. So pretty much I know, I have a finger on what happens across the 36 states and FCT. Now, in terms of benefit package, our benefit packages are as robust as they should be. Where the challenge is, we continue to insist, is this. Our people, when they come to register, I use Anambra for example. When you register in our scheme, we give you a pamphlet listing the benefit package, giving you the phone numbers to say, look, when you get there and you are denied these services, please call us. And then in every provider premises, you have a flex banner reflecting all of the benefit package, the services that we cover. But then you get there. It is a contractual obligation. You have service level agreements to say, look, when you come to, when somebody has paid, who is the principal, using a principal-agent relationship, you, the healthcare providers, you are the agents to render these services, and we are the people who purchase these services for our principals, who are and then you are the agents. But these principals get to the facilities and they are denied services. We do mystery shoppings, we do all manners, we do quality assurance visits to ensure that people get value for the money they have paid. But I'm using this opportunity to call on us to truly begin to call out providers who fail in their responsibilities. And again, I will say to you that that is one thing decentralization policy has done for us as a country. Because in the past, the redress mechanism was like a command and control kind of center thing, where a HMO or the regulator or the purchaser have an office in Abuja, Lagos, or Port Harcourt, and then someone goes to hospital somewhere in Aguleri, in Anambra State, and then when that person is shortchanged, to make the call to even complain for the purchaser to begin to address it will take weeks for you to get responses. But with decentralization policies in our various states now, the offices are in our various state capitals, with local government offices, with staff manning those places, it is easier to get these complaints addressed. And how do we know that this is beginning to work for us as a country? I said to you, and it's on record, our coverage was less than 5% for a very long time. But within the last...
Are you saying categorically that for sufferers of diabetes, kidney diseases, Nigeria's healthcare coverage insurance scheme covers these healthcare challenges, and they do not need to spend, from their own pocket on healthcare for these challenges? And anyone who is doing that is out of ignorance, has not registered on the healthcare insurance scheme?
Categorically, we cover hypertension, diabetes. For example, I'm first a medical doctor before becoming a public health expert. Now, there are kidney diseases which you are using as an example, okay? Does not just develop in one day. Most of the causes of renal diseases in our own environment come from poorly controlled diabetes, poorly controlled hypertension. When you take care of those conditions, the tendency for individuals to come down with renal diseases, which can then take their lives, become very, very minimal. So, with a financial access mechanism, which the various state health insurance schemes and the national health insurance scheme is providing for our people, when you have these financial access by paying your premium, whether in the formal sector, you are a civil servant at state level or federal and what have you, or you are someone in the informal sector and then you have paid your premium, you get to these facilities. Right. What this is to guarantee is that people should have uninterrupted access to taking their medications. If you have diabetes or hypertension, you are expected to live on medications all your life to control the numbers as well as prevent the complications, which renal is. But kidney dialysis, for example, for most of our schemes is not covered. That is that particular service, dialysis. But then we have interventions by various state governments where you have free dialysis programs going on here and there. But the basic thing is to understand that when you do the needful, which is controlling those things that will lead you as a complication, if they are not properly controlled, to having renal diseases as a sequelae, then you are good to go.
For what it's worth, I'm glad we're able to have this conversation, know the kind of work that has been done to this point and what we have to do, in the coming year, or this year as it is. We have to thank you so much. It's enlightening to hear the work you do. We've been speaking with Dr. Simeon Oyemachi, who's MD, Anambra State Health Insurance Agency, and also a member, Forum CEOs of State Social Health Insurance Agencies in Nigeria. You say for as low as 8,000 naira, right, people can get coverage?
depending on the state. In
All right.
Anambra is 12,000, for example, but I want every Nigerian to know
Dr.
in this new year that you have state health insurance schemes working across the country.
All right.
Go and subscribe and stop paying out of pocket. We die
right.
needlessly, quite frankly.
Thank you so much for your time, and to have a great 2025.
Thank you.
We'll take a moment now, and when we return, we'll bring you some good melody, and you can take this to the bank. So stay with us right here. Still the Morning Brief.